So the background to this is that, as you all know, we've been seeing this really big influx of newly diagnosed diabetics presenting quite acutely in Birmingham, and I'm sure you have in Wales as well. But we know that the diabetes process has probably started 6 to 9 months previously to that. So there's this gradual loss of functioning beta cells over some period before they present acutely. This has now been put into or classified into stages, really for the purpose of trying to identify stages when you can intervene and do something about the natural history. So according to this classification now, stage 0 is when maybe one antibody might be developed, but to all intents and purposes, one has a complete complement of pancreatic beta cells and no symptoms whatsoever. Stage 2 is when there are 2 or more antibodies, but people have got a normal complement of beta cells and are able to maintain healthy levels of glucose without going to the dysglycemic range. That's stage 1. Stage 2 is when dysglycemia occurs under conditions of stress and pancreatic beta cells start being reduced. And stage 2 is the stage at which they're presenting with acute osmotic symptoms that we all see, plus or minus type 2 diabetes, plus or minus diabetic ketoacidosis. Okay, next slide, please. So this has just been shown here, and the concept really is that the trouble is we're now seeing all these children presenting with diabetic ketoacidosis, and I'm sure, like you, you've also seen them as well. We've seen some really acute patients over the last year with COVID as well. And that's obviously a big concern that people are presenting like that they have at the moment. If it was possible to actually try and catch our patients earlier before they've developed symptoms, and that might be able to prevent them developing diabetic ketoacidosis, and maybe even earlier, before they've started losing pancreatic beta cells, and whether there's any interventions that might be able to be done to actually preserve beta cells and stop the process from snowballing as it's going through. So Rachel's come up with this concept really about trying to identify children who we know inevitably are going to develop overt diabetes before they present acutely, and so hopefully preventing diabetic ketoacidosis and having this sort of gradual development of symptomatic diabetes with good education to prevent acute complications occurring at presentation. Okay, next slide, please. So we all know this, and you all know this as well from that area, that we see a lot of diabetic ketoacidosis in the UK. The national figures, I think, are about 20 to 25%, and of course, it variations around the country as well. It's particularly present in children where there's no family history of diabetes, and so perhaps there's less awareness of the symptoms, the osmotic symptoms. And the graph on the right, shown from Diabetes Care, really demonstrates that children who are presenting with diabetic ketoacidosis tend to have higher HbA1cs, suggesting that they've had high glucose levels for longer before they're presenting. But unfortunately, there's some prediction from that about long-term outcomes, in that the group who presented with the most severe DKA often might have higher HbA1cs 10 or 12 years down the line. And then, of course, we all know about the risks for cerebral edema and the associated morbidity with this as well. So we really don't want patients to present with diabetic ketoacidosis if we can help it. Okay, next slide, please. What I think has become apparent, and what I've learned over the last few years from the last couple of years reading around this, is very nice data from Annette Ziegler and others showing that the development of antibodies really can predict who's actually going to develop type 1 diabetes. And you can see on this graph on here, this is following up people with antibodies, the number of antibodies, and then over up to about 15 to 20 years. And you can see the top blue horizontal line at the top of the graph is those that don't develop any antibodies and don't develop diabetes. The next line down is people who developed one type 1 diabetes autoantibody, of whom a few develop type 1 diabetes. But then the next two ones, the green and the purple line, show people who have developed 2 or even 3 antibodies, usually under 5 years of age. But as you can see with progression, they almost all will develop diabetes by the time they get to 18, so during childhood. So the development of 2 or more antibodies in the first decade of life predicts people who have got a greater than 95% chance of developing diabetes by adulthood. Okay, next slide, please. Thank you. So this really shows that there is a population out there for once they've developed multiple antibodies that you know are going to develop diabetes, and therefore, at least in theory, you can advise those parents to look out for the symptoms of diabetes, osmotic symptoms, and any suggestion of that, catch these children and get them presenting earlier rather than waiting for them to develop diabetic ketoacidosis to do that. And the other exciting thing, which is not yet here in the UK, but you may well have, I'm sure you'll have heard of some of the clinical trials published in the New England Journal of a drug called teplizumab, and then there's been another drug since then as well, giving these to people with multiple antibodies who are first-degree relatives of known diabetics and delaying the development of diabetes by up to 2 or 3 years. So really exciting research coming at the moment, but not yet licensed for use in practice at the moment. Many of these studies have been done on first-degree relatives of people who've got diabetes, but as you know, they make up a very small proportion of the total number of children we see with diabetes, and most people who we see in clinic don't have family relatives with type 1 diabetes as well. Okay, the next slide, please. So the issue then is, if one was going to try and develop a screening program to pick up children with multiple type 1 diabetes antibodies who you know are going to develop diabetes, what age would you hypothetically do that? And the graph on the right was just a nice paper, again published by Annette Ziegler in 2016, showing really the on the y-axis the number of multiple antibody positives that you've got, and on the x-axis the age of presentation. And what you can see is that by 3 or 4 years of age, a proportion of children have developed multiple antibodies, but not many have yet developed diabetes. And by 17 or 18 years of age, there's only a few children still developing multiple antibodies, and the majority who are going to get diabetes have developed it by then. So you really want to try and catch that optimal period when children are developing antibodies, but not too many have developed overt diabetes. And it looks like that is somewhere between about 3 and 10 years of age, but might be an optimal time for screening. Okay, the next slide, please. So Annette Ziegler is the lead diabetologist in the Saxony region in Germany, who's actually undertaken a population screening, and they were able to do that in Germany. They managed to screen about 100,000 or more children between about 3 and 5 years of age for type 1 diabetes antibodies through their community pediatric network. So they have a different health system, obviously, than we do here as well. What they were able to do was to pick up out of those about 0.3% of children who had multiple antibodies. And following those up over a period of years, they published that in JAMA last year, showed that they could dramatically reduce the DKA rate from about 20 to 25% down to about 3.5%, something like that, by picking children up at the multiple antibody stage and producing an education program for parents. Now, when we spoke to Annette Ziegler, we said, well, what about parental anxiety you're inducing in all those who are not going to develop diabetes at all? And the published data suggests that, yes, while there was parental anxiety at the time of the positive result, if these patients were followed up, that levels of anxiety returned back down to baseline levels after about a year of follow-up altogether. And that they really felt that their experience in Germany, the benefits to the population who were going to develop diabetes outweighed the risks of potentially parental anxiety in the general population. Okay, next slide, please. So with Professor Colin Diane, Parth Narendran in Birmingham and the ELSA study, and led by Rachel Besser here in Oxford, she's developing a program now to look at the possibility or the feasibility of a finger prick type 1 diabetes antibody test. And this would be timed to be done alongside preschool vaccinations, so children about 3 to 5 years of age, to try and identify around 4/5 of the people who are likely to develop type 1 diabetes, based on that graph that I showed a couple of slides back. That children who were antibody negative could be reassured that they would have a very low likelihood of developing diabetes, and children who had multiple antibodies could be explained that they were likely to develop diabetes, but put into an education program to looking for osmotic symptoms and warning them about the signs, so that when they did develop overt diabetes, that they could go straight into treatment without developing diabetic ketoacidosis. So there are proposals at the moment for a feasibility study and an acceptability study to have a look and see the feelings of the general population about this. Okay, the next slide, please. So this is some of the information that they're proposing to use. That, as we know, type 1 diabetes starts before you need insulin. And if you know somebody who's very likely to develop it, or highly likely to develop it, we can put steps in to prevent them developing diabetic ketoacidosis and improve, hopefully, long-term diabetes outcome as well. Now, we also know, although it's not part of this proposal, that there will be prevention trials coming to the UK over the next couple of years. And if it's possible to identify children with multiple antibodies who we know are going to develop diabetes, they may then have the opportunity to take part in trials of new drugs that can change the natural history and even delay the onset or the presentation of type 1 diabetes. Okay, the next slide, please. This has also been pushed along because, at least in North America and about to be launched in the UK, are commercial companies offering antibody testing for a fee, of course, to the general population. And this has been launched in the UK now and actually been endorsed by the Juvenile Diabetes Research Foundation. I do worry about this, I must say, because the kits that are offered are home testing kits for antibodies, but there's no real follow-up offered for people who've been identified as positive. And I do feel it would be safer to do this in the context of a feasibility study where measures could be put in place to support families who are antibody positive or anxiety than just on a commercial basis that you can just get the test online. But it does raise the question about whether we should be looking at this in the NHS. Okay, next slide, please. And this is just Rachel's cartoon suggesting that if we can actually develop education materials for people who are going to develop diabetes that prevent them developing diabetic ketoacidosis, that would be so much better than the current situation that we have in Birmingham and you may well have in Wales. Okay, next slide, please. Right. So in a very small pilot study so far that Rachel has done in the Oxford region, she's asked primary care healthcare professionals what they thought about it, of whom the majority were in favour of antibody screening. They felt that finger prick blood tests shouldn't interfere with vaccinations, but obviously there is what we don't want to do is affect the uptake of vaccines, of course. And then she surveyed about 30 paediatricians, or at least Dr. May Ing did via Twitter, of whom the majority were in favour of an antibody screening programme, especially if you could prevent diabetic ketoacidosis, and felt this was a really good idea. And you can see some of the comments there as well. We have. There obviously was some concerns about anxiety and also potentially about additional work provided to diabetes teams as well. But overall, people thought the benefits would outweigh the risks from this. So the purpose of this presentation really is just to sort of alert the paediatric diabetes communities around the country, and May, Rachel, myself and Tabitha are talking to different regional diabetes groups as well, just to get some feedback if people have got any experience really of this situation where they've got maybe unaffected SIBs who are multiple antibody positive, who parents know are likely to develop diabetes at some point, or indeed personal views about whether this might be acceptable to both the health professional community as well as patients as well. Okay, next slide, please. That we have, and that if there is any feedback or if any of you would be interested in getting involved in this project, please do contact Rachel Besser. She'd love to hear from you, myself potentially, but also Colin Diane as well, who is really leading a UK consortium to look at early interventions so that we can try and do something to change the natural history of diabetes. And I have to say, from my point of view, I've been in diabetes practice now for over 30 years, and I'm just fed up of the next newly diagnosed diabetic presenting to the emergency department of the Children's Hospital, and there's been nothing I can do about it to try and prevent them developing diabetes and coming into hospital. And it would be so nice to actually, now that the technology and the evidence is available now, to try and think about the feasibility of screening tests to try and step in earlier to prevent children presenting quite as sickly as they have done with the DKA recently. Okay, that's as much as I wanted to present, and I said I'd keep to less than 15 minutes, so I think that is less than 15 minutes. Thank you very much for giving me the opportunity, and I guess if there are any questions, I'm very happy to try and answer them to the best of my ability.
Thank you so much. I don't know if anybody's got any questions. We're trying to run it through the chat, but if people want to put their hands up, I've got one hand up, but Julie Haycox, I think your hand's been up historically. I don't know if you want to pop it down. And if anybody did have any questions for Professor Barrett. Rebecca?
Thanks, that was a lovely talk, and just giving us a glimpse of what's going to come across the pond, I think. I was quite interested to see on your slide that it said JDRF subsidises the cost of the home kit to $10. And I'm just wondering if that is the case, whether we need to suggest to JDRF, if they're going to do that here, that they need to help us put an education program together for those families before they just subsidise the kit, because we're going to be having phone calls coming through that we're going to have to field otherwise quite soon by the looks of things.
Rebecca, I think that's a really, really good point. And of course, in North America, they have a different system. They can get lots of these tests online, but they don't necessarily provide the follow-up that's going to accompany it. So I think you raise a really important point about that. Yes, I believe Colin Diane and Rachel Besser are talking with JDRF and Diabetes UK on two fronts. One, to fund this feasibility and acceptability study, and two, to try and channel the availability of the home kits, the testing here, through a clinical trial if possible. I'm not sure how successful they're going to be, because I think the commercial company is going to try and offer this anyway, even if it's at more than $10, even if they don't get the subsidy. So I suspect we're still going to have families who are prepared to pay £100 for such a test, and will still be coming to us wanting to know what to do with the results, because the commercial company will give no more than an information leaflet about it. But I think it's a really important point, and I think as a diabetes community, we perhaps ought to be making representations to JDRF and Diabetes UK to make sure they take our views into account. You're right.
Thank you, and perhaps even having sort of standard responses that we can share with families in the event of positive results. And
yes, that's right, and I think the part of the difficulty is that we don't yet have that agreement or that consensus within our paediatric diabetes health professional community. We've got some markers, some ideas, because as you know, the TrialNet natural history study was all about identifying first degree relatives with multiple antibody positives, and then they were putting them into a program of follow-up. So we do have a basis from which to produce it, but what we need is a multidisciplinary consensus advice to pull together across our community, I think, really, about what we're going to do, seeing as we can see this coming down the tracks to us. And we just all need, ideally, we all need to be saying the same thing, whether you're in Swansea or Solihull, you know, so that we give the same advice.
Thank you. I think someone else has got their hand up. I can't see who it is. So could you identify yourself if you've got a question, please?
Hi there, it's Rhian from the paediatric diabetes team in Cardiff and Vale.
Thanks,
Hi
Rhian.
there. I'm a psychologist. It was great to hear your talk. Thank you for that. It's reminded me quite a lot of the TrialNet study, which you did just mention. And I went to a talk on that a few years ago. My concern from it was the psychological support that families would receive, because it is noticed that anxiety, it might come down, but it does increase. And I'm dredging my memory here, but there was a study called TEDDY that found behaviour changes in parents when they received this news. And again, I'm picking them from the top of my brain, but I'm sure it was things like increased testing and perhaps behaviour changes around food. There was something to do with carbohydrate counting when they had this news that there was an increased risk. So my question was around what psychological support would be in place for those families receiving this news that their child might be at an increased risk of type 1 diabetes, so that it doesn't fall on the local diabetes teams.
Yeah, I think that's a really important point. And yes, the TEDDY study was looking at the environmental determinants of diabetes. So they were looking at sort of early life influences around food and toxin exposure in the environments and things as well. But they also included antibody positives, as you said. From what I'm aware of it, this tended to be sort of information leaflets that was given out to families rather than bespoke clinical psychology support sessions on there. And I think in the UK, we would want to do a bit better than that. so that these families who had children that were multiple antibody positive were offered something more, probably including a face-to-face appointment. The thing I think that's worth bearing in mind is that the numbers would be quite small. So the estimates, I believe, that if you were screening 100,000 children or something like that, the number that would be multiple antibody positive would be 30 to 50. It would be quite small numbers out of that. However, that is going to be a capacity burden on services, because I think only the paediatric diabetes services will be in a position to actually provide that support. Again, which is why I think we need to be thinking about this now, because like it or not, it's going to come to us, and we're going to have families approaching us with this. So I think you raise an important point that hasn't yet been resolved about who is going to provide that support and where's the capacity going to come from.
Thank you. It's good to hear it's being considered. Thank you.
So we've got another question from Mike Cronin.
Yeah, could I just ask Tim what he would do now if a family presented to him saying that they had done one of these tests and one of their children had picked up one antibody, say, how he would progress with that?
Oh, that's great, Mike. You always ask the difficult questions, Mike. That's great. I think if it's one antibody, I think one would have to say that there's not an evidence base for following up those patients, that they're at a low risk of developing diabetes, only just a little bit more than the general background population, and that I wouldn't recommend any particular follow-up for that. If there are two antibodies or more antibodies, then my experience is based on the TrialNet natural history study, which when it was fully funded was offering 6 monthly follow-ups. I think it was actually 6 monthly glucose tolerance tests. I think that's quite invasive, but I would certainly probably want to keep them under review on a 6 monthly basis and at least offer an HbA1c or a random glucose to check that. So what I would do would be based on what I did for the TrialNet natural history study for those patients. Yeah.
Okay, thank you.
Thank you very much. Did anybody else have any questions before we close this topic off? I think that we're going to have, as you say, a lot of questions raised in the coming months and years, and I think it will be really important to have a UK-wide strategy to sort of respond so that it doesn't require individual teams to scratch heads. It's just, well, this is this, so we'll do this, this, and this. This is the plan. So, yeah, I think that would be the most helpful thing for teams on the ground.
Yeah, exactly. That's great. Thank you very much for inviting me, and thank you for giving me the time.
Thank you very much for coming. It was a really, really useful presentation. Thank you.
Thank you. All right. Nice to see you. Bye bye.